Anniversary Day all over the world. The topic for this year has been healthcare in the new millennium. At the outset, my congratulations to Dr. Tabish for his book on hospital and healthcare administration. And it is every penny worth the price tag of 2,000 rupees a book. In 53 years, we have traveled a lot. From an impoverished society, especially people living within the mountains of the valley, barely having something to eat 2 times a day, wearing shoes made of grass, while literacy was non-existent. Healthcare was very rudimentary, and that too highly urbanized. A few doctors in Srinagar city and Jammu. It is nothing short of a miracle that has been achieved. Sher Kashmir used to say, قوم کے 2 ستون ہوتے ہیں اور جتنے وہ مضبوط وہ ستون ہوں اتنی مضبوط کوئی قوم ہوتی ہے. ایک ستون تعلیم ہے, دوسرا ستون صحت. اور یہی وجہ تھی کہ آخری دم تک انہوں نے یہ 2 قلمدان یا تو اپنے پاس رکھے تھے یا اپنے رفقا کے حوالے کیے تھے جن پہ ان کو بھروسہ تھا اور قابل تھے. اور سب سے بڑی رکاوٹ جو ان 2 ستونوں کو, جو بنیاد ہوتی ہے کسی قوم کی, ان کو مضبوط کرنے میں سب سے بڑی رکاوٹیں جو ہے وہ غریبی ہے یا غربت اور جہالت, اگنورنس اینڈ پاورٹی. حکومت میں ہونے کے ناطے ہمارا کام اولین یا پرائیورٹی ہماری ہمیشہ سے رہی ہے, جب سے بھی یہاں عوامی سرکار بنی, کہ جہالت اور غریبی جو لعنت ہے کسی قوم کی, اور ہر ترقی میں سب سے بڑی رکاوٹ ہے, ان کو یہاں سے بینش کیا جائے, ختم کیا جائے. اور جو افلاس یہاں تھا 53 سال سے پہلے, اس کو ہم نے پچھاڑ دیا ہے اور کوسوں اتنا دور پھینک دیا ہے کہ دوبارہ اللہ تعالیٰ کے فضل و کرم سے وہ کبھی اس وادی میں یا اس ریاست میں وارد نہیں ہوگا. اور یہ فخر کی بات ہے, ریاست جموں کشمیر جو ہے سارے ملک میں, سارے برصغیر میں جو ہے ایک ایسا ہیلتھ کیئر سسٹم یہاں لوگوں کو دیا ہے جس کی مثال کسی اور جگہ اس برصغیر میں نہیں ہے. میرے پاس اعداد و شمار یہاں ہیں, وقت ملا تو بتاؤں گا کہ ڈاکٹرز کتنے ہیں اور انسٹیٹیوشنز کتنے ہیں اور پیرامیڈیکل اسٹاف کتنا ہے. اور یہ جال جو ہمارا ہیلتھ کیئر کا ہے یہ ریموٹ سے ریموٹ کارنر تک چلا گیا ہے. پرائمری, سیکنڈری, ٹرشری اور اب سپر یا اسپیشلائزڈ ہیلتھ کیئر انسٹیٹیوشن جس میں آپ بیٹھے ہیں. یہاں روشنی ہر پہلو پہ ڈالی گئی. صحت کا دار مدار جو ہے بنیادی چیزوں پہ, اچھی خوراک ملے, صاف شفاف پانی ملے پینے کے لیے, اچھی نگہداشت ملے, بالخصوص جو گربوتی ماں بہن ہو, حاملہ عورت ہو, اور اس بچے کو کئی سالوں تک نگہداشت ملے, اچھی سی اچھی خوراک ملے. جب اس کی فاؤنڈیشن لگتی. اور سب کو جانکاری ملے کہ صحت کے لیے بنیادی کیا چیز ہے. اچھا ماحول ہے, اچھی سینیٹیشن ہے, اچھی خوراک ہے, اچھی تربیت ہے. یہ ساری چیزیں جب ہم عوام کو دے پائیں گے تو آپ دیکھیں اڑن شو ہو جائیں گی. اتنی بیماریاں, جتنا بھی زکام وغیرہ کی باتیں ہوئی ہیں, ایسی بیماریاں ہیں کہ آدھی سے زیادہ جو بیماریاں واٹر بورن ڈیزیز جو ہیں وہ غائب ہو جائیں گی. اور جیسے کئی ملکوں میں آپ بیماریوں کا زیادہ تر یا اسٹروک ہے یا ٹیوب کینسر ہے یا ہارٹ کی ایلمنٹ ہے یا کڈنی کی ایلمنٹ ہے یا ایسی ایسی موٹی موٹی چیزیں ہیں. باقی چیزیں جو 90% ہم پرائمری, سیکنڈری, ٹرشری اور آپ کے انسٹیٹیوٹ میں جن بیماریوں کا علاج کرتے ہیں وہ مشکل سے دکھیں گے. بہت کچھ حاصل کیا ہے آپ سب کی نظروں میں. اگر آپ سب لوگ بھی پیچھے کی طرف نظر ڈالیں تو ہم سب کے بابا و اجداد نے وہ غریبی, وہ افلاس دیکھا ہے اور اس کی پریشانی اور کمر توڑ حالات سے گزرے. اب ہمارے پاس جو سسٹم ہے, جو ایک سسٹم اچھی طریقے سے چل رہا تھا اور ایک منصوبہ بند طریقے سے سارے دیش میں آگے بڑھ رہا تھا. پاپولیشن کے حساب سے آپ کا سب سینٹر ہے, پاپولیشن کے حساب سے آپ کا پرائمری ہیلتھ سینٹر ہے, پاپولیشن کے حساب سے کمیونٹی ہیلتھ سینٹر ہے, پاپولیشن کے حساب سے آپ کا سب ضلع ہسپتال ہے. اس میں دھکا لگا اور جو معمول کی دیکھ ریکھ تھی, اس کی مرمت تھی, جو سسٹمیٹک طریقے سے چلتی تھی, اس میں گیپ آ گیا 6, 7, 8 سال کا. اور راستہ فرار اختیار کیا ڈاکٹروں نے بھی, پیرامیڈیکل اسٹاف نے بھی. اربنائزیشن, یہاں ایک طرف پاپولیشن کی ہو گئی, وہاں اربنائزیشن آپ کی میڈیکل پروفیشن کی بھی ہو گئی. باقی جو بڑے بڑے پروفیشن ہیں ان کی بھی اربنائزیشن ہو گئی. There was flight of talent from the periphery for various reasons. One of the reasons was militancy. The other reason was neglect, because people who were supposed to maintain it couldn't go. And third was the people who were supposed to work in those places found themselves unsafe, either in the place of work or at the time of travel from and to their workplace, from their home to the workplace and back home. Infrastructure is not now at this present stage in those peripheral institutions which would reduce your headache, as was mentioned here by the Vice Chairman. Those people with minor injuries or minor cold would not come to your portals, would not come to your door. But now the medical profession expects the minimum basic comforts in the places of their work. Radio now is a thing of the past. Television with the added facility of hooking on to channels and knowing what is happening all over the world is now a necessity, not a luxury. A cold glass of water in summer is now a necessity. And a place which has a decent rooms where you can stay, where you can cook, where you can eat. It has a good toilet facility. All those schemes have been drawn. But unfortunately, most of the money, if not all, is going towards security-related matters, which includes defense, which includes paramilitary forces, which includes police, and everything connected, which includes salaries to migrants, is also security-related expenditure. On the one hand, we have a problem. On the other hand, we have, like mentioned here, resource crunch. The reasons for resource crunch in our state, where everything is going in a big chasm, which I have repeated on many occasions is a waste of money. Waste of money in Syed, waste of money here in those matters which never existed before 1990. And as a bonus, on the negative side, we have human blood everywhere in the state. I think every 10 kilometers there's somebody or the other who has lost his life. Now these are challenges, the environmental changes brought about by overambitious developed part of our globe, which despite being, as mentioned here, 3 to 4% of the population, contributing up to 40% of pollution into our environment. Greenhouse gases, which has resulted in depletion of our water reserves in the form of ice, snow. All these are challenges. And these challenges have to be met. You have to do it professionally. We have to look at all aspects. We have to see that on the ground, each and every soul in this state has a peaceful and contented life. As long as that is not available, it won't be normal for us who are in the government. And even to get that peace, the problem is not within. The problem is without, from outside as well, which are beyond our control. So all these things put together shouldn't dishearten anybody. If good times don't last, bad times won't last either. We are in a tight spot as far as the government is concerned. But we are gradually coming out of it and trying to give a clean, healthy government to the people, looking after all their problems, including the basic problem and problems that are connected with international global warming, greenhouse gases, international politics, where a country is starved of funds, where young children by the hundreds die. We don't have to go to Iraq for that matter, where such things happen almost every year, and the whole world, represented by the world body, turns a deaf ear and a blind eye. In the country which is next to our neighbor, 500 children have died for want of food. So they have their own priorities, as rightly put here. Whatever is with us, we have to develop that, build that. And you are now the laboratory. The forefathers created it, you are the laboratory. You will teach the future generation and prepare a workforce that will fan out into the remotest corners of our state and bring the disease to discipline. And it's an ongoing process. After every milestone, a new milestone has to be achieved. New things are on the horizon. This genetic engineering, they link all diseases to genes. And some good day in the future, maybe they have a genetically engineered human being who is absolutely free from all disease and hunger, perhaps doesn't even need to eat food. Even they will link eating food to gene. So it will go to a ridiculous, hopefully, I hope it doesn't go to such ridiculous heights, where the very fact that machine has come to us, we have become now more, not slaves as yet, but fast moving towards that, where machine seems to get the first priority, and that human touch and the clinical eye, which is so vital. All of you have it. Only thing is you have to give bigger exposure to that. Nevertheless, these are changing times. It's the 21st century. People may go for super genetic treatment to the moon. They might set up a station there. You never know. Science has so much possibility, unlimited possibility. But what we pray and strive for is a healthy and content society. With whatever we have to make good with the facilities, whatever we have. I wish you all the best. You are the cream of our profession. You are the cream of our society. Everybody looks to you. Previously I went to Rajasthan, Jaipur. There was no medical college here. And people have gone to as far south as Kerala, as far east as Calcutta, braving all those hostile environment, both political as well as climatic, and then come back and pass out. Now we have those facilities here. Thank God for that. Now to conclude, my very best wishes to the Institute, my very best wishes for the success of this seminar. We have to go on to greater heights of excellence for better service to the common man. Thank you very much.
Thank you, sir. I now request the organizing secretary, Dr. Riaz, to give a vote of thanks.
Honorable Chief Guest, Dr. Mustafa Kamal, Vice Chairman, Governing Body, Dr. Mattoo, Director, Sher-e-Kashmir Institute of Medical Sciences, Professor Merajudin, Dean, Medical Faculty, Professor S. Jalal, Head Department of Hospital Administration, Professor Qadiri, faculty members, distinguished guests, resident doctors, ladies and gentlemen. It is a matter of great privilege and honor for me to present the vote of thanks on behalf of the organizing committee of this seminar on healthcare in New Millennium. At the outset, I express my sincere gratitude to Honorable Minister for sparing time out of his busy schedule for this seminar on the World Health Day. I am thankful to the Vice Chairman Governing Body for being present and gracing the occasion. I wish to thank Director, Sher-e-Kashmir Institute of Medical Sciences for has been a constant source of encouragement and advice and has made vital contribution to make this event possible. The organizing committee is greatly indebted to Dean, Sher-e-Kashmir Institute of Medical Sciences, who kept himself available for every possible help and advice. I am greatly indebted to Professor G.J. Qadiri, Dr. I.A. Bukhari, and Dr. Tabish for their enthusiastic support and encouragement in all the aspects of this seminar. But for their encouragement, organizing this event would have been impossible for me. I am also thankful to Dr. J.N. Kasba, Joint Director, for his advice. I am extremely grateful and indebted to my friend, Dr. Shaukat Hussain Khan, for his untiring efforts for making this event a great success. I am greatly obliged by our guest speakers who at a very short notice agreed to deliver lectures in the scientific session. I do understand that all of them are very busy people, and despite of that, they have come over to grace this occasion. I make use of this opportunity to thank all of these distinguished personalities very profusely. I would like to thank all of our sponsors, particularly Jammu and Kashmir Bank, Hussain Brothers, Ramzan Hospital, and Dabur Pharmaceuticals. Let me take this opportunity to thank Chairman J&K Bank, who lowered the minimum deposit to operate ATM accounts, which was inaugurated today. I am thankful to Exxon Electric Sanitation Officer, Security Officer, Officer in charge Transport, Officer in charge Clinical Photography, Officer in charge Landscape, and Department of Estates, particularly Assistant Engineer Civil, Mr. Zohur Ahmed Pandit, for their cooperation and support. I would be failing in my duty if I do not thank all those people who contributed, even in the smallest way, and whom I have forgotten inadvertently. Last but not the least, let me once again thank all of you for coming over and making this event possible. Thank you.
Thank you, Dr. Riyaz. Ladies and gentlemen, I now request you all to break for tea before we reassemble for the scientific session at 12:30. Thank you.
Talk in the scientific session, and they're all guest speakers, very popular people. May I request Professor Imtiaz, Head of the Department of Community Medicine, to give a brief introduction about the theme of WHO today, that is mental health. Professor Imtiaz.
I have actually just requested the organizers that I would like to just speak for 5 minutes about the World Health Day theme, which unfortunately none of the speakers, even during inauguration. I'm sorry I don't have any slides because it's just a last minute entry. Therefore I'll be just speaking for 5 minutes only. The theme for today is mental health, stop exclusion, dare to care. WHO, World Health, the Director General has decided to devote World Health Day 2001 to mental health. This day is a part of a systematic process for awareness raising and advocacy aimed at improving mental health situation in the world. The latest statistics says that around 0.8 to 1.6% of the people in the globe are mentally ill, and 1/3 of them are the children below 25 years of age. Now that is the main magnitude, and that is the problem, that people thought that mental problem is more common in the elderly, but that's not true. It's more equally 1/3 of them are the children which is suffering. Therefore WHO thought that because of mental illnesses people get neglected, we should devote a day on that particular area. WHO recognizes the countless efforts which have been made by many organizations to bring attention to the burden caused by mental health problems. WHO understands that this is not a problem which can be solved in isolation and welcomes the involvement of other partners in planning activities around the world here. The day is mainly focused to bring attention to mental health issues and reach usually unreachables. It should be used for awareness raising within the public at large, constituting all target audiences within and beyond the health sector, the health ministries, the health professionals, the health insurers, patients, consumers, families, media people, educators, students, and average citizen. The day should be a rallying point, an opportunity for generating enthusiasm to boost long-term actions, promote tolerance, inspire self-reflection, and encourage those making a difference to stay the
He is an alumni of Government Medical College, Srinagar. He did his post-graduation from prestigious All India Institute of Medical Sciences and MAMS from National Academy of Medical Sciences. He completed his postdoctoral fellowship in epidemiology and social medicine from England. Other fellowships to his credit are from International Medical Sciences Academy, Delhi, Royal Institute of Public Health, England, New York Academy of Sciences, United States of America, Institute of Health Services Management, London. He has 150 research publications to his credit. Other than medicine, Dr. Tabish is a known literary figure with over 300 literary publications to his credit. Dr. Tabish has represented, as was pointed out earlier also, India at the World Health Forum in the United States during February-March 1998. He is the editorial advisor for the Journal of Management in Medicine, United Kingdom. He has been the editor of Journal of Hospital Administration and is the guest editor for Journal of Indian Society of Health Administration, ISHA. It's indeed a matter of honor and privilege for me to invite him to speak on healthcare in the new millennium. Dr. Tabish.
Health is fundamental to quality of life, and health service is a personal answer to personal needs. Healthcare is the largest industry, and its sheer size and complexity makes changes and evolution of mammoth proportion. First slide. When we look back at the 20th century, 20th century has been century of human achievement. When we look ahead, the 21st century is expected to be a century of human development. Next slide. Uh, 20th century, some of the determinants of the health, which includes right from education, water, sanitation, housing, then socio-economic development, healthcare, resources, organization, management, delivery, accessibility, quality, etc. Work environment, employment, social organization network, living family conditions, age, gender, genetics, and lifestyle. Next slide. There has been a health transition influenced by demography and epidemiology. If we look at the health states of countries, particularly developing ones, there are stages of the health development. The low-income countries have the high mortality and high morbidity, particularly because of the infectious diseases. And middle-income economies do have lower mortality, much lower, and the high-income countries, developed economies, have the least. And this rapid population growth, the demographic transition, without corresponding economic growth, leads to decline in income, reduces the ability of the country to finance education, health services, sanitation, safe drinking water, etc. There is an example here. Bangladesh has the population at par with that of the United States of America, but its land area does not exceed that of this North Carolina. That's one of the states of the USA. Next slide. We also witness double burden of disease. We are living under two shadows. One is that of the infectious diseases, and another growing shadow of non-communicable and chronic diseases like heart ailments and cancer. Health transition due to demographic and epidemiological change like lifestyle and industrialization influences the national health policy, or should influence the national health policy, which should result in total restructuring and revamping of the healthcare delivery system. Next slide. There has been a gradual decay in the health services. You all know there was an outbreak of malaria in virulent form, or return of dengue in Delhi in 1996, or for that matter, plague in Surat in 1994, or for that matter, the emerging infectious diseases like Ebola, hantavirus, and increase in the cases of the tuberculosis related with STDs, particularly HIV infection. Next slide, please. We also witness inequalities in healthcare delivery system. This is one of the major challenges for the medical scientists to tackle. If we quote Bangladesh, there you will observe 1 out of 8 children die before they reach the age of 1, as compared to Japan, where it is 1:142, or the Scandinavia, where it is 1 in 125. So Sub-Saharan Africa is much worse, where the death rate among children from the first and to the 4th year is 20 per 1,000. And in developed countries, it is 1 per 1,000. South Asia and Africa, out of 20 million children born with low birth weight, 13 million were in South Asia and 3 million in Africa. So here is the case of example of Zimbabwe, where you have 14 per 1,000 among whites, but if you see 140 to 200 among blacks in the rural area, or for that matter China, it is less than 40 in the cities and urban areas, but the disparity remains. It is more than 100 in counties in the countryside. Next slide. We are living on the edge. World has over 50 billionaires. Their assets exceed combined income of the 50% of the world's population. These are obscenities of excess in a world where 160 million children are malnourished, 840 million live without secure sources of food, 1.2 billion lack access to safe drinking water. But there is a ray of hope. That's the immunization, which saves more than 3 million lives per year. Next slide. If we look at the Darwinian theory of natural selection, people with poor health move down the social scale, and people with good health move up the social scale. So there is a social divide. Our medical community has to ponder how to bridge this divide. Next slide. The dichotomy exists in the health infrastructure, which in India is said to be unresponsive and extremely uneven. One can hardly believe that they are part of the same nation. Or within the states, you have black areas, gray areas, as compared to the green ones. Next slide. You are cholera, anthrax, then Lassa fever, HIV, then Ebola, yellow fever, cholera, diphtheria, so on and so forth. Next slide. When we look at the epidemiological perspective for healthcare management, population's ability to benefit from the healthcare should be the primary concern of planners and policymakers. Health services have to be based on the needs assessment of the population on one hand, and effectiveness of healthcare on the other. Next slide, please. The 20th century include, for example, working for the patients, caring for people, health of the nation, patients first, patient charter, league tables, population health outcome indicators. And like you had in the Britain, National Health Services, there is increasing emphasis on consumerism, value for money, and further professionalization. Next slide. The pressures which are emerging for the policymakers and planners of the healthcare is, number one, managing demand because of the population explosion, growth of the middle class, and more demand from that middle class. So it is the number one pressure. Then you have to manage the supply, you have to manage change because of the advances in knowledge and the technology. You have to also manage the bureaucratic wealth. Advances in medical technology has also given changes in the expectations of the people because the patterns of the disease and illness have changed. There are external economic forces which influence the healthcare delivery. Next slide. Emergency healthcare is one of the priority areas identified by World Health Organization in addition to the provision of primary healthcare. These two areas, WHO recommends that this should be provided to, it should be universal. That means it should be accessible to all. We have seen tragedies like Bhopal gas tragedy, earthquake in Mattoo, Gujarat, super cyclone in Orissa, and when we are able to manage these emergencies properly, we will definitely be able to reduce the mortality. But the tragedy is emergency services have been ignored so far. We do not have emergency medical services which we could boast, which we could be proud of in any part of India. Next slide. It's concerned. Since 3/4 of the healthcare delivery system is in the hands of the private sector, total is about 6% of the GDP as compared to the 15% of the United States or 10% in Switzerland and Canada. Next slide. We must invest greater proportions of GDP on health. Next slide. Medical education is an area of great concern. Today, medical education in India is at crossroads. Society wants comprehensive, relevant, affordable, equitably accessible and quality care. And the doctor of the future is expected to be a caregiver, communicator, decision maker, community leader, and a good manager. Medical universities must introduce accountability, academic autonomy, quality, and new methodologies to prepare the doctor for the 21st century. Next slide, please. New methodologies like problem-based learning should be introduced, or assessments have to be changed, teaching and learning methods have to be changed, like simulation, computer-assisted learning, or multimedia should be introduced. And last but not least, research must be given a priority. Next slide. The challenge which the healthcare system faces is number one, is primary healthcare. We have not been able to achieve health for all by the year 2000, which is known for all. And technology is a persistent problem because technology changes every moment. Then quality of care has to be looked into. Rising costs is a concern. Privatization is the buzzword, and consumer protection is also coming up in a big way. We must eradicate poverty if we really want that the health of the people should improve. Next slide. Next slide. Hospital continues to be a center of excellence, though majority of the budget is spent on hospitals in India. Yet the concern about the quality is there, because in medicine we cannot afford poor quality and patient safety cannot be compromised. Next slide. There are various methods of improving the quality which I don't want to mention because of the constraints of the time, but continuous quality improvement is one of the latest buzzwords which should be introduced in healthcare institutions, particularly teaching ones. Next. This is an era of accountability. Everybody must be accountable for his work, and the intervention, medical intervention, has to be evaluated so that we invest more on the interventions which are cost effective and beneficial. Next. Health services research must be a priority for the health manager, administrators, or the managers. Next slide. And regard for standards that, for that matter, there is an urgent need to have an accreditation body which is either autonomous or semi-autonomous on the pattern of Joint Commission on Accreditation of Hospitals of the United States of America, so that we are at least able to observe the minimum standards of health care or medical care. Next. Good health must be a goal for us. Next. India must have a national health services on the pattern of United Kingdom. There you have a national health services, where here we do not have one. Next. Can I like mention a word what Archie Conferene, who is the founder of this Conferene collaboration, interested in systematic overviews, what he has said half a century ago. My colleagues, in their devotion to their patients, evoke my admiration, but also remind me of Agatha in Iliad, the family reunion who wanted action. Not for the good it will do, but that nothing may be left undone. On the margin of impossible, I hope clinicians in the future will abandon the pursuit of the margin of the impossible and settle for reasonable probability. Here is a whole rational health services to give. Thank you.
Any comments? So then thank you very much, Dr. Amin. Let's go to the next speaker.
Syed graduated from Government Medical College, Srinagar in the year 1976. He completed his post-graduation from the same college in 1981. In 1985, he was awarded DM in endocrinology from the prestigious Postgraduate Institute of Medical Sciences, Chandigarh. He has about 100 international and national publications to his credit. Professor Zargar is the first clinician to document genetic transmission of prolactin deficiency, prolactin resistance, and growth hormone insensitivity in this part of the world. He has generated some of the biggest epidemiological data on diabetes mellitus and infertility. Professor Zargar has participated in numerous international and national conferences and is currently involved in a good number of international projects. Professor Zargar currently heads the Department of Endocrinology at Srinagar Institute of Medical Sciences. He is one of the most loved teachers by the postgraduates and residents. It's a matter of great honor and privilege for me to invite Professor Abdul Hamid Zargar, who will be talking on emerging trends in endocrinology. Professor Zargar.
And I hope that I'm given around 20-25 minutes or how long, so that I accordingly curtail my talk, because I think we have 5 minutes from Dr. Amin Tabish's talk.
You have 20 minutes.
Okay, thank you. Thank you for this magnanimity of 5 minutes. I'll be briefly telling you about what my perceptions are, primarily about endocrinology and what I believe is going to happen in the field of endocrinology in years to come, in the light of what we are seeing happening in endocrinology today. It's like what our vice chairman said, that how some of the things, how dismal some of the things are. And then our honorable minister said that if we look back, then things don't appear that bad if we enumerate what has been happening in the last 5 decades. In a similar fashion, in different areas, globally, in the area of diabetes mellitus. The sheer figures, the sheer magnitude of the problem the world over has been overwhelming everybody. In 1995, in fact it was in 1994, WHO took over a global project to estimate on the basis of the available data what would be the scenario of diabetes in the world in the year 2000 and how it is going to worsen by the year 2025 and put in place the mechanism to combat this growing mass. May I have the first slide, please? Now this is what WHO came up with. India has the dubious distinction of being labeled as the diabetes capital of the world. In 1995, in India we had more than 19 million diabetic patients. And it was projected by the year 2000, this figure will go up to 30 million. And by the year 2025, this will cross 57 million people. And by the year 2000, these figures have already been surpassed. There was some debate that some of the data that have been incorporated in the WHO database were slightly exaggerated, but we have already crossed the deadline of year 2000. The data has proved predictably right. The only part of the world where the total quantum of diabetes per 1,000 or per million is going to be worse than India is going to be Pakistan. See, it has the dubious distinction of crossing from position number 8 to position number 4 by the year 2025. So there is a ravaging epidemic, not only from Kashmir to Kanyakumari, but from Peshawar to Kanyakumari. So we need to, when you are talking about diabetes, we are not talking about writing a tablet. We are talking about millions of people having it, millions of people suffering from the tremendous morbidity and mortality associated with it. Next slide, please. Now, we have our own share of it. Epidemiological studies have shown over a period of a time that in our own valley, 14.23% adults 40 years or older are liable to have some form of an impaired glucose tolerance, which may be either true diabetes or impaired glucose tolerance alone. If to these figures we add the recently devised category of impaired fasting glycemia, then these figures go up to 20%. Now all of us know that impaired fasting glycemia and impaired glucose tolerance are by no means any innocuous disorders. Not only they are the harbingers of potential diabetes, but independently indicate a strong correlation primarily with coronary artery disease. Next slide, please. So what are the areas that are going to come up? That are going to emerge in view of all this data? There was a $1 billion study which spread over 1.5 decades throughout North America, which confirmed that if you adequately and ideally contain and treat diabetes, the complications of diabetes could be reduced by more than 50%. And in rest of the people, the onset of these complications could be delayed by more than a decade and a half. In the light of this data, there has been a steep increase in the use of insulin pumps, which are trying to give as near a blood glucose to an individual as is humanly possible. I visualize in years to come, more strenuous efforts would be made in this regard, that one is able to achieve as near a normal glycemia as is humanly possible. Next couple of decades are going to concentrate on that, because this is what medicine demands, this is what healthcare demands, and realizing that you have millions to treat, this is what market demands. So this is going to be driven. It's a fait accompli. Next slide, please. All of us know who have been associated with medical care that how scared our patient population is of insulin injections. The number and types and the myths that are associated with these injections are innumerable. And it is shocking to know that these myths are not unique to a relatively less educated community like ours, but they are more universal. These myths and misconceptions, even though in a relatively lesser quantum, do exist even in the most sophisticated parts of the world, like North America and Western Europe. So, the market-driven forces have seen to it an alternative is developed. For long periods there were trials for development of oral insulin. They have not met with much success, but now insulin in the form of inhalations is in the final phases of management and final phases of experiments, and I'm convinced it may not be long, maybe as early as the end of this year, that we see marketing of some of the insulin inhalers. I'm not saying that's going to be the last end. What I visualize is that people are going to continue using a long-acting insulin with short puffs of insulin whenever they eat anything. The problems of constituting it are getting refined right now. I think they will be over by the end of this year. Next slide. Another area that has caught the attention of endocrinologists and endocrine surgeons for the last 4 decades has been the pancreatic and islet cell transplants. The first pancreatic transplant was done in 1966 at the University Hospital of Minnesota. Surprisingly, for 4 decades, major success has been eluding the surgeons. But now, in the last 4 to 5 years, quite a few encouraging studies have come up which have shown that at least in patients with type 1 diabetes mellitus, where diabetes is basically very fragile, is brittle, patient is relatively unpredictable because of his or her age, these options are going to be practical options in a decade to come. Next slide. Probably the best thing that has happened in the management of type 1 diabetes in the last decade is the process of implanting islet cells. The first and the most successful study was published in New England Journal of Medicine just last year. It was from a Canadian group where the success rate at the end of 1 year was more than 90%. The primary success of this management by that Canadian group was a major alteration from the conventional immunosuppression, which was a steroid-free immunosuppression, which the students of medicine by now know as Admn protocol. And meeting different guys in different international fora, one understands that similar trials are now going on in an experimental stage in different parts of Europe and North America, outside this hospital in Edmonton, Alberta. And it's going to be probably the most astonishing, simplified procedure if the technical details of this are sorted out. It's going to get far simpler than actual pancreatic transplant. Next slide. Gene therapy, I will not go into the details of it, is again a fait accompli. One is trying to use a surrogate hepatocyte to induce the insulin gene to see that it produces insulin. I do not see this becoming a reality in next half a decade, but work in about a dozen centers is right now in progress to see how this could be carried through. Next slide. Next slide. Now, apart from type 1 diabetes, which forms a relatively small group of total diabetics, when we are talking about millions upon millions of these diabetics, we are talking about type 2 diabetes, where we need to watch what we eat, because most of these happen to be obese individuals. So a large citrus is going to be placed on obesity, what we eat and what we drink. May I have the next slide, please? In contradistinction to what one used to believe that probably obesity is immense of the developing regions of the world alone. Surprisingly, even though a good part of us is starving and starved, but obesity is and will continue to be and will probably grow in its magnitude in areas like ours as well. Next slide. So I visualize a lot of pharmacological and non-pharmacological intervention emerging globally to contain this epidemic. My personal belief is for a decade to come, drugs which are already in the market, which are in the experimental trial, I would not call the results very encouraging. But you never know what's going to hit the market. Now, leaving the diabetes, second most important area that WHO has been insisting on. Probably this should have been the first one, but because I thought we've been talking a lot for a decade on iodine deficiency, you might be a little bit bored for starters. Iodine deficiency does not mean a goiter, I emphasize, at all stages, be a fetus or an adult. This is what all of us should be and are primarily concerned with, what it does to our cerebral functions. Next slide, please. 1 billion people at risk, and this has already been revised to 1.5 billion people, and so simple to tackle. Next. As most of us happen to live in this region, and most of the human beings are inhabited by this region only, so most of this risk is in Southeast Asia, and understandably we constitute the major component of it. Next slide. We have conclusively proved that we live in a significant iodine deficient area. This debate has long back been closed. We need to put in measures so that this is actually eradicated rather than keep on debating on this. Next slide. This is a landmark study. I remember when the study was published, I was so ecstatic, and because in the department we had been at times discussing that are we overemphasizing the role of iodine. Then I caught Professor Wahid and said, come and sit in my office, and I said, why? He said, I want to show you a paper. This is a paper that has been reconstructed with a lot of hard work. Blood samples were retrieved from mothers who had delivered in various hospitals in North America in 80s, and thyroid hormone estimation was done on that. There was no overt hypothyroidism in those individuals, but those guys whose TSH was upper normal, they were segregated, mothers I mean, from those whose TSH was middle or lower normal. Then they went back and did the psychometry of individuals who had been born by these mothers, these kids, children. Surprisingly, individuals who were born to mothers whose TSH was normal, but on the higher side, had an IQ score lesser by 7 points. And the editorial in the New England Journal of Medicine says, come what may, whatever the debate, supplement iodine in whatever you can, at least in pregnant mothers. And this is what is happening in North America, where we believe iodine deficiency has been eradicated long back. Next. And what do I visualize? I visualize novel methods of giving iodine to people. There are people who are obsessed to eradicate it. And this one study will tell you what has been achieved in a province in China. This put or supplemented irrigation water with iodine with remarkable results. There was a steep decrease in the infant mortality in individuals who were born in that area once this water iodine supplementation was put in place. So I see a lot of novel ways of giving iodine to people in years to come. Next slide. The third area where a lot of concern has been shown is infertility. It afflicts huge chunks of population, a lot of money goes into it. A lot of citrus so far has been put on female infertility. Male infertility, I must tell you, is as important as female infertility and probably has a much worse prognosis than female infertility. What do I visualize here? Next. whether you document an iodine, this growth hormone deficiency or not, whether you document a definitive endocrinopathy or not. What do I visualize happening here? Next. Next. With the massive and easy availability of recombinant growth hormone, how do I see the things emerging in this area? Next. Not only is growth hormone likely to be given in patients who have genuine growth hormone deficiency, where there is no debate, idiopathic short stature, Turner syndrome, it is already well established and people are already using it. In idiopathic short stature, massive trials are on, benefits equivocal, but still people are trying it. And a huge barrage of indications are already coming up. Next slide. Like even people have been trying to give it to people with achondroplasias, hypochondroplasias, even when people know that spending $1 million is going to give them only additional 2 inches. I know guys who are prepared to do that. And that's going to happen more frequently in years to come. Next slide. A unique thing that I'm seeing happening in years to come in the field of growth hormone related disorders is this area. This is a unique disorder that has primarily been described from Israel, we can actually say Palestine, southern Ecuador and Kashmir. Growth hormone insensitivity, where you have megadoses of growth hormone in the circulation, but patient still presents with growth hormone deficiency-like clinical picture. This primarily is because of the absence of a growth hormone receptor on the hepatocyte, which ultimately ends up in synthesizing growth-promoting factor somatomerin, and this receptor is absent there. I see IGF or